At this point, we've gone over your history, your physical exam, and your imaging, and we've identified that you have a symptomatic rotator cuff tear that is sufficiently symptomatic that you would like to pursue rotator cuff repair. Now, you've seen the arthroscopy video, on-shoulder arthroscopy, and I would like you to review the risks and complication video. But this video is to go over the specifics of the rotator cuff tear and its repair. Now, the rotator cuff itself has a propensity for tearing, and that's in part due to its tenuous blood supply. The rotator cuff tendon is the confluence of the 4 muscle tendon units as they insert in a horseshoe shape on the proximal humerus. And the blood supply comes from the muscle bellies of the rotator cuff musculature, the subscapularis, supraspinatus, infraspinatus, and teres minor. And as those converge on the humerus, there is a watershed between the blood supply from the musculature and the blood supply from the bone. And the tendinous portion is at that watershed. And when you look at the rotator cuff tendon, it is virtually white because of poor blood supply. So multiple small micro tears may coalesce into partial tears that can progress to full thickness tears. And rotator cuff tears may be due to repetitive microtrauma or single macro trauma on a tendon that was predisposed. So that there are certainly biological factors that contribute. But you also have to consider that the rotator cuff has a relatively short lever arm. If you think of the rotator cuff inserting on the humeral head, the center of rotation is only about 1 inch from the insertion on the rotator cuff. And then you look at the length of the lever arm of your arm when you go to lift, there are substantial forces on the rotator cuff. So the mechanical environment that it's in, the poor blood supply, and it is between the humeral head below and the acromion above, so that there can be impingement. The function of the rotator cuff is to act as a depressor and a centralizer of the humeral head on the glenoid. And when it's not functioning, when there is pain that inhibits muscle function, the humeral head can ride up, and that can result in impingement. So there are a variety of factors that may contribute to rotator cuff tears. As a result, we see a lot of rotator cuff tears, and when they're sufficiently symptomatic, we treat it with repair. This is done arthroscopically. It can be done open, but an open exposure requires taking down the deltoid. It has to be then reattached, and there's greater morbidity for the patient with an open repair. We can also see the pathology better arthroscopically than at open surgery. So over the last 2 decades, we have been doing rotator cuff repairs entirely arthroscopically. This is done again in the lateral decubitus position. We use the posterior portal as the initial first viewing portal, create an anterior portal, do the glenohumeral arthroscopy, address any associated intra-articular pathology, and assess the rotator cuff. The extent of the tear, the location of the tear are identified. The footprint is initially provisionally prepared on the articular side and a suture marker placed, and then the arthroscope redirected up into the subacromial space. Rather than being in the intra-articular space, we're up in the bursa and looking down on the rotator cuff from above. We first have to remove the inflamed bursal tissue. There is a posterior bursal shelf and a lateral bursal curtain that are removed, which creates a room with a view to allow us to visualize the rotator cuff. And we identify the landmarks, the acromion, the AC joint, the spine of the scapula. And we are using the suture marker along with direct visualization of the rotator cuff to identify the tear pattern. We look at the lines of tension and look at the direction, whether this is a crescent tear, a U-shaped tear, an L-shape or reverse L-shaped tear, and define the direction of forces to reduce the rotator cuff back to its anatomic attachment site. So once we've identified the tear pattern, we'll prepare the tuberosity, and we do that with a combination of removing any excess soft tissue on the tuberosity, because this does not contribute to healing. We'll use a shaver and occasionally a light touch with a burr, but usually most of the preparation could be done with a shaver and rasp to be sure that we're down to a raw bleeding bony bed for reinsertion of the rotator cuff. We then will place suture anchors into the bone, pass sutures through the rotator cuff, and then secure the rotator cuff back down to the bone. The specifics of the tear pattern dictate whether this is requiring some side-to-side margin convergence sutures or whether it's all tendon to bone, and whether or not this is a double row repair or a single row repair. These are all possibilities, and part of the interesting elements of treating rotator cuff tears is that they're all somewhat different, and one requires a variety of techniques in addressing the different tear patterns. We also will add a decompression if there is significant spur formation on the overlying acromion, because that can contribute to impingement. If this is the humeral head and this is the acromion, if there's a hook or prominence of the acromion, that can contribute to impingement, and we try and remove any prominence to create a flat surface so that there is less potential for impingement. Having addressed the rotator cuff tear and the impingement, as well as any intra-articular associated pathology, dressings are applied. We use a DonJoy Ultra Sling, which is a shoulder immobilizer with a small abductor pillow, which keeps some of the tension off the rotator cuff. And we use a cryocuff, which is a cooling device circulating ice water to help with pain and swelling control. The procedure is typically done with an interscalene block and general anesthesia, as we mentioned in the initial shoulder arthroscopy video. And so when you come to recovery, the shoulder is numb. As the freezing gradually wears off, we'll use pain medication to keep the pain under control. The block may last anywhere from 8 hours to 24 hours, and sometimes longer. And that provides a period of initial comfort, and as it starts to wear off, you'll add pain medication. You will be briefly in recovery, then over to ambulatory, and then discharged home. We will set up outpatient physical therapy. I routinely call and speak to the physical therapist to let them know the arthroscopic findings, and you'll be placed on a appropriate rotator cuff repair protocol. We have specific protocols for small, medium, large, and massive rotator cuff tears, and this helps to guide the physical therapist in terms of the rate of progression of the rotator cuff repair protocol. The physical therapist is important because one can overdo or underdo the physical therapy. On the one extreme, if we were to immobilize the shoulder completely and not move it, we're at risk for developing a frozen shoulder. And if we're too aggressive with lifting the arm, as we lift the arm, we're pulling right on the rotator cuff repair, and we're at greater risk for rotator cuff tear. So it's important that you're not actively lifting the arm with your own muscles, but that we do some gentle pendular exercises. We'll use some pulley exercises. The therapist will assist you with gentle motion while at the same time protecting the rotator cuff against excessive force. So It is important to work with the physical therapist in order to try to avoid, on the one hand, a frozen shoulder, and on the other hand, a re-tear of the rotator cuff. We'd like to have our cake and eat it too. We want to avoid the frozen shoulder, but we want to avoid re-tear, and the assistance of your therapist will help guide you through that process. Of those two extremes, I would prefer a frozen shoulder to a re-tear because the treatment of the frozen shoulder is not as involved as the treatment of a re-tear of the rotator cuff. One also has to remember that the rotator cuff is a slow healing structure. It heals at a rate of about 10% a month. Again, that's because of its poor blood supply. The skin itself heals about 10% a day, but the rotator cuff at about 10% a month. So if you think about that for a minute, we're talking 9 to 12 months for full recovery. Bear in mind that anyone that has had a rotator cuff tear is at increased risk for re-injury and re-tear. Although it's repaired back to the bone, it heals with scar tissue, and the scar tissue is not as robust as the original rotator cuff tissue. Also bear in mind that the factors, the biomechanical factors, are still there. Hopefully we've improved the blood supply somewhat with our preparation of the bony bed, but the cuff itself still has relatively poor blood supply, which contributes to the slow healing rate. So be patient, don't push it, don't overdo it, to try to minimize your risk for a re-tear. Now, this discussion may have raised questions, and I'm going to meet with you again, and I'll be happy to go over any of the questions that you may have after watching the video on risks and complications, shoulder arthroscopy, and rotator cuff repair.